Lawrence, thank you. It's Sahil Parikh from New York. Thanks for your great presentation. I mean, I think the discussion around atherectomy has become controversial for a host of reasons. And as a drug delivery science person, I believe that vessel prep has a theoretical advantage of improving drug delivery, but it probably is true for DCBs and stents also. Um, I guess I would ask people like Nick Shamus, who are on the panel, who've got a lot of experience with intravascular imaging in anticipation of atherectomy and then drug delivery, to comment about what their role, what they feel the role of atherectomy is in their treatment algorithm.
Well, Sahil, thank you very much. We've learned a lot with intravascular ultrasound imaging, particularly vessel sizing, and use of the DCBs. And of course, the extent of dissections that have remained pretty much underappreciated. Even, when you do something like a jet stream or others, and you think, you have no really deeper dissections, you'll be surprised what you see with an intravascular ultrasound. So there's clearly a lot of findings on the IVUS that may change our strategy to optimize post-atherectomy, use of drug-coated balloons. I would personally think the sizing is critical, so you can choose the right size balloon post-treatment, as well as lesion morphology, so you can decide how heavily calcified that vessel and what type of atherectomy device or a vessel prep device you're going to be using. I think IVUS is going to be a major player. Again, precision imaging will lead to precision in the decision-making process. And I believe we need a trial, that would be focusing on an IVUS-based outcome, which currently we really don't have in the periphery.
May I ask a question, a short question with regard to your lessons learned from the use of IVUS? Did you change the sizing as compared to angiographic sizing? Meaning, are you up or downsizing your balloons now?
Yeah, actually, Thomas, just the other way around. When we look at the QVA, we're finding out that we're really undersizing, particularly in the smaller vessels like the infrapopliteal segments. And the average undersizing has been about 25 to 30%, depending on the the measurements that you use by IVUS. We tend to use internal elastic to internal elastic lamina measurement. I know a lot of people use media to media and some external elastic to external elastic. I think these are minor, small differences in the measurements. The bottom line is when you get an accurate measurement by IVUS, it changes your perspective to the size of the DCB balloon that we'll be using and how you approach, the treatment of that vessel. We tend to use internal elastic lamina measurement.
Lawrence, can you mute your microphone? I think it might be on.
Maybe Professor Zeller. Thanks. So I think that's an interesting question. We can talk a little more about imaging and the measurements. For coronary operators, we're used to using media to media. I think in other spheres, they might use different measurements. And I use different measurements depending upon the technology, whether it's a balloon, a self-expanding or balloon expandable stent. I think we get different levels of injury when you use different measurements. But Rob, you've got a lot of experience with all the different technologies. And as a radiologist, what's your perception of the role of atherectomy? Do you use it for calcium specifically? Do you use it to debulk, to enhance drug delivery? What's your thought process when you pull an atherectomy device?
Sure, thanks, Sahil. So, I think we all struggle with what's the ideal lesion subset that we feel comfortable using atherectomy on. You've touched upon a few of them. Certainly for dense, severe calcification, I embrace atherectomy. I use it liberally. I really think that our outcomes for example, DCB, or even for DES in the setting of dense calcification, unfortunately, are very limited. And I feel very comfortable using atherectomy for that lesion subset. For in-stent restenosis, I think that's another great lesion subset where I think we all have anecdotal experience. There's some limited trial data that shows that balloon angioplasty alone, even drug-coated balloons alone, just aren't really getting us the long-term patency that we're looking for. And I feel very, very comfortable using a debulking strategy for in-stent restenosis as well. I think that what I struggle with is for the routine lesion when either on angiography, duplex, IVUS, you don't see dense calcification, even mild calcification. What's the role? And I think that's a great opportunity for us to generate, prospective randomized data. Lawrence touched upon some of this, but I don't think it's really coming to exactly answering this question, which is, should we be using atherectomy routinely for all lesion subsets, or just for these high risk subsets? And I personally think there's just a lot of huge opportunities to generate prospective research moving forward.
That's great. I agree with you. The evidence gap is substantial, and even reality is largely a registry series. So we've seen some of the appropriate use criteria for device selection give atherectomy relatively low grades because of the lack of randomized prospective data. So hopefully we can fill that gap.
Sahil, can I ask a question?
Sure.
I ask a question? I have a quick question to ask. I was going to ask anybody, but maybe Manish can comment on this. Manish, one of the challenges many people have raised to me, colleagues out there practicing, is that, as you know, we are not reimbursed for DCB. And many of my colleagues feel that that is, from a standpoint of efficacy at least, that's the approach to take. Many of these lesions are long, require 2-3 DCBs. The cost is not covered. They feel that there is reasonable data with atherectomy. Yes, there is no level 1 data, as we just discussed, but there's reasonable data, number of registries, prospective, core lab. And they feel like this is a way they can utilize DCB in combination with atherectomy to treat their patients. Otherwise, they will have to give them angioplasty alone. And the financial aspect of this is the reality of life. I mean, they have to run their practices. The hospitals have to run. What are your thoughts about that, given the challenges that we have with reimbursement for DCB and technologies that are effective?
Yeah, I think this is a critical question. And I think Sahil was just speaking to it, which was about, I think we have data, but the data we have doesn't always follow the payment. So we talk all the time about precision care. We've been speaking more and more about precision payment. We would love to have the payment follow the evidence. And I'll just say that in the periphery, one could argue right now that something like atherectomy, which we just talked about, gets reimbursed much higher than something like DCB, and that's a key thing that we all have to sort of struggle with and work on. I think the way forward is going to be, unfortunately for us in the United States, I don't know about Europe, that the payments are going to be bundled, and we're going to have to start to show what the evidence is for the things we do for that bundled care payment.
Thanks. That's a great discussion. I think we're going to move on to the next talk, and I'm delighted to introduce Professor Tomas Zeller, who's going to enlighten us about the role of DCB versus DES in FEMPOP disease.